Namaste everyone. At the very outset, I'd like to thank Sri Lankan Orthopedic Association for inviting me in this meeting to deliver a talk on my favorite topic. I come from Nepal, and then Nepal is known for the birthplace of Lord Buddha, which is from Lumbini, and it is also known for the place of Mount Everest. My work profile, I work in two centers of Kathmandu, Nepal. One is a private hospital, which is a 300 bedded hospital, which is known as B&B Hospital, where I have my own setup of AKB Center for Arthroscopy, Sports Injuries, and Regenerative Medicine, where we see all types of, knee injuries, shoulder injuries, and sports injuries. The another avenue where I work is probably one of the unique hospital, which is the only pediatric hospital of the country, which is known as Hospital for Rehabilitation of Disabled Children, where I see lots of these patella anomalies in pediatric age group as well. So what I'm going to talk today is about the patellar dislocation. Basically, I'll be talking on understanding the pathology and tailoring the treatment based upon the pathology. I am Dr. Amit Joshi, an arthroscopy surgeon from Nepal. So let me, divide my presentation into 5 groups. So I'll be basically talking on basic understanding of cause of patellar instability, menu a la carta, which is the common, implemented treatment modality for patellar instability, how to decide which surgery is appropriate for that particular patient, and how do I prepare my own menu for a particular patient. And I'll also, in the course of this presentation, will share some of our cases. So let's start with the basic understanding of the cause of patellar instability. It may seem very simple for all of us, but I'll spend some slide to emphasize on the basic understanding of patellar instability. So this was the first case as a 13-year-old boy, repeated injury of left knee 3 times, all the time while playing football, and after 6 months the patient presented to us with MRI and the X-ray. So if you see this, clinical examination video, you'll see that the patella is subluxed and patella is dislocated laterally. So we did a MPFL reconstruction. My favorite technique is superficial quartz technique. So we did a superficial quartz technique MPFL reconstruction in this patient, and you can see in 3-year follow-up, the patient was having absolutely normal knee range of motion and he was able to go back to his sports. In contrast, this was another case number 2, a 26-year-old lady. She underwent 4 surgery, 2 on the either side, for recurrent dislocation of the patella, but she was not able to extend her knee actively, difficulty in standing, running and jumping, and there was a severe limitation of activity of daily living. If you see her video, specifically look at the on the left side, she is not able to extend her knee from sitting position, so she uses another leg to extend the knee. So this disability, even after 2 big surgery, you can see in the scar on her left knee as well as on the right knee. So what went wrong? Why case 1 was a success and case 2 was a complete failure even after 2 surgeries? So if you look into these cases, the case 1 had only soft tissue injury. There were no bony underlying causes. That's why we did a soft tissue reconstruction, MPFL reconstruction in this patient, and that's why he did well. Whereas the second case had the underlying bony cause, she had a trochlear dysplasia. But what we did just a soft tissue process, ignoring the trochlear dysplasia. That is the reason why 2 big surgeries have failed. So what I want to say, that the bony cause cannot be corrected with soft tissue repair alone. This is a very important principle we have to understand when we start treating the patellar instability cases. So first take home message is about the basic understanding of cause of patellar instability. Understanding the cause of dislocation, either it is bony or the soft tissue cause, is very, very important. Bony cause cannot be corrected by soft tissue repair alone, and if bony anomalies has caused soft tissue damage, bone and soft tissue both must be addressed. The only exception is immature bone, in which we have limited bony surgical options. We all know that there was an era when we understood the vital role of medial patellofemoral ligament, and we thought that medial patellofemoral ligament is the sole primary stabilizer of the patella. But over a period of time, we have understood that it is not only MPFL. There are other several soft tissue structures which are very, very important for the stability of the patella. That's why these are called as a MPFL complex. I'll not go into detail of all these structures, but I would definitely suggest you to read this very 2024 paper on patellofemoral instability part 1. It's part 2 yet to come. And this clearly shows that it is not only MPFL, but they are MQTFL, MPML, MPTL, and patellar tendon, quadriceps tendon, then the lateral structures. All these have a vital role to play for the stability of the patella. And what this paper concludes, that MPFL is always torn, or MPFL complex is always torn, but it may not be cause of the dislocation. So identification of cause of dislocation is of paramount importance rather than just reconstructing or repairing the soft tissue constraints. So there are basically 3 causes of patellar dislocation. So to simplify all these, so number 1 is soft tissue cause, when soft tissue is not able to bring patella into the trochlea, like in MPFL tear or patella alta or even patella baja. The second cause is the trochlear cause, when your trochlea, where the patella has to glide, is already abnormal and your gliding of the patella is unstable. And the third thing we very commonly neglect is the abnormal alignment. Either it is varus, valgus, femoral rotation or the tibial rotation. All these components can lead to patellar instability. So my second important take-home message for all of you is that identifying the cause of patellar dislocation is the most important factor in deciding treatment and achieving realistic goal. So all the effort has to be paid so that you identify the causes which is causing the patellar dislocation. So how do I do that? I do that by doing lots of investigation. This is one condition in which I exhaust all my investigation modalities in identifying the cause of patellar dislocation. And these investigations are lateral x-rays. Lateral x-rays are very, very important. But unfortunately, in my practice, what happens? When I do a lateral x-ray, which is essentially a true lateral x-ray, which is required for assessment of the trochlea, I get this type of oblique x-rays, and it's very difficult to analyze, trochlear dysplasia from this type of oblique lateral view. So what I do, I take the patient to a minor OT where I have availability of the C-arm, and then I examine the knee under C-arm. So I take true lateral, I take at 30 degree, 40 degree and 90 degree knee flexion, so to measure the the patella height, and then a true lateral view just to measure the trochlear dysplasia, which I'm not going to detail about this, but this picture shows that there is a trochlear dysplasia in this patient. Of late, this is again a very 2024 paper. Of late, what we understood that the X-ray analysis of trochlear dysplasia is extremely difficult, and it is observer, inter-observer and intra-observer reliability is there. So that is why we started combining the X-ray finding with the MRI finding of trochlear dysplasia. And this is one of the paper which is published again in 2024, which says that probably MRI is a better investigation, and the adapted scheme shows almost perfect intra-reader reliability and a significant higher inter-reader reliability than the established description. So that is why it depends upon spur and cliff, and if there are no spur, no cliff, this is type A, Desor type A. If there is only spur, no cliff, it is type B. If there is no spur, only cliff, then it is type C. And if there is both spur and the cliff, it is type D. So based upon this, I classify them into Desor A, B, C and D. Of course, I take help of the X-ray as well. Scanogram, very rarely done, for this patellar dislocation, but this is extremely important investigation. And then I suggest all of my patients who had either primary or recurrent patellar dislocation to get an standing full length scanogram done, and then this gives us lots of important information. CT scan again is very, very important. All the cuts, especially in CT scan, I look for TTTZ distance, which shows basically the rotation of the tibia. And then in CT scan, I do a femoral versions, both proximal femoral and the distal femoral version by the overlapping images of the CT scan like this, which will give us an idea that if the femur is internally rotated in the proximal part or in the distal part, so that we can plan for the rotational correction as well. MRI is, the one of the most important one, and it is important not only for the classification according to the Desor, but for the assessment of the cartilage as well, because if it is a recurrent patellar dislocation, there is a cartilage damage which completely changes our understanding of patellar dislocation and the treatment. So the third important take-home message is a thorough investigation that is required: X-ray, scanogram, CT scan and MRI. And it is important to know what to see in all these X-rays or the investigation modalities. Coming to the menu a la carte, so menu a la carte approach is the most popular approach for management of patellar instability, and this literally means that ordering the dishes from the menu. So you have a menu, then among this menu you order the dishes you want. That is what means a la carte. But unfortunately for patellar instability, there are 75 various dishes of soft tissues and more than 100 bony procedures. So which one to choose sometimes becomes very difficult. So that is why this is a very simplified menu by Elizabeth Arndt, and she says that if there is MPFL tear, perform a MPFL reconstruction, which is in most of the time MPFL tear is present. But if there is a patella alta or baja, then you have to do a tibial tubercle osteotomy. If there is a trochlear dysplasia, do a trochleoplasty. If there is a rotational deformity, derotational osteotomy is required. If there is a valgoid knee, corrective osteotomy is required. If there are TTTG distance, TTTG ratio is altered, which is basically more than 20 mm, then medialization or the lateralization of the tibial tubercle is suggested. So the fourth take-home message is to prepare the menu. We must know the ingredients of the patellar dislocation in that particular patient. So what I do, how do I prepare my menu is most important. So this is my menu. This is a standard format I always use in all of my patient of patellar instability. So what I do, I identify these 8 parameters: MPFL tier, skeletal maturity, Couto-Descent ratio, scanogram, trochlear dysplasia, TTTG distance, femoral torsion, and any other specific findings. I identify everything, and then I decide based upon these identification. I order my menu. I order my food. If there is MPFL tier, I suggest MPFLR. If there is a skeletally immature, bony procedure can be done. If skeletally immature, bony procedure is not done. If patella alta or baja, tibial tubercle osteotomy. In scanogram, if there is a varus or valgus malalignment, osteotomy has to be done. If there is a trochlear dysplasia, trochleoplasty, TTTG distance, medialization or lateralization, femoral torsion, and if there are any specific, then I do a specific treatment. Let us see some of the examples. So this was a 22-year-old female. There was no history of trauma, pain right knee, difficulty in running. She noticed the abnormal patella movement, and this is the menu card that we prepare, the patellar instability profile in each of our patients. So this is our clinical video. You can see that in clinical video, you will see that there is a J sign positive on her left side. There is some maltracking on the left side also, but she was mainly symptomatic on the left side. The X-ray was done, which showed patella alta, Couto-Descent ratio 1.5. There is an osteochondral fragment. Scanogram, the sagittal alignment was normal. We did MRI, which shows the type 1 trochlear dysplasia. The TTTG distance was slightly raised of 24. Then the femoral torsion was checked in both proximal and the distal. It was within normal limit. So this is the menu that we prepared: MPFL tier, CD ratio 1.5, TTTG 24, osteochondral fragment. So what we suggested for that patient is MPFL reconstruction, TTO, medialization, and the fixation of the fragment. That is what she got, MPFLR, TTO, excision, and the BMAC for the cartilage defect. And this is after 1 year of that same lady. You could see that she is absolutely normal, was able to do everything, and now we were preparing for the surgery on her. Right side. So this is all united and healed. Another case, a 12-year-old, first time patellar dislocation, scanogram normal, MRI and the CT scan was done. You could see that there was a small bony fragment, osteochondral fragment in this one, and then this was the menu that has been prepared. So MPFL tear and the osteochondral fragment. So the treatment suggested for this patient was MPFLR and the fixation of the fragment. So you'd see we did a open fragment fixation and the superficial quartz technique of MPFLR, and this is what the patient received, and after which he did very well. This is another case, case number 5, a 26-year-old lady, which again I showed in our initial discussion, underwent 4 surgery, 2 each for recurrent dislocation of the patella. She was not able to extend her left knee, difficulty in standing and walking. I've shown you this video. You see that is severely disabled lady. This was her X-ray, trochlear dysplasia, again the oblique view which was not correct. This is CT scan, MRI, and based upon all this examination, we identify that she was having MPFL tear and the trochlear dysplasia type D. So the treatment suggested for her was MPFLR and the trochleoplasty, and that is what she got. I do an open simple trochleoplasty. This is the process of trochleoplasty, and this is at the end of the surgery after MPFL reconstruction and the trochleoplasty. You can see that the patella is right at the center, and you see after 8 months follow-up she was able to extend her knee, and she was comfortable on this left side. And then the next surgery was done after 8 months on her right side. This is another case, 19-year-old female failed MPFL using superficial quads and TTO 2 years ago. So this is what she was having after 2 years, habitual patellar dislocation, and then even the surgery has failed. So when we started examining based upon our menu, we found that there was a valgus, valgus alignment of the distal femur. In the CT scan rotational profile, we could see that the distal femur was more of a internally rotated. So this was the menu created for her. MPFL tear, Couto-Dessin ratio 0.7, but Labbaha actually she had. So we had to do a proximalization of the tibial tubercle, and there was a femoral torsion, internal torsion. So we did a derotational osteotomy. So this is what she received: MPFL, derotation osteotomy, and the posterior, proximalization of the tibial tubercle. Finally, the last case is a very special case, a 12-year-old girl, patellar dislocation since childhood, and this is extremely difficult to treat because we cannot do a bony procedure, and she was having the same thing on both the sides. So we are talking about the left side first. This is habitual dislocation of the patella. She underwent all the investigation and the menu was created. So what we found that there was a patellar instability, immature bone, so we cannot do a bony procedure. She was having trochlear dysplasia, but trochleoplasty cannot be done. So in these cases, in adolescent and the pediatric age group, we do 4-in-1 procedure, which includes lateral lengthening, tube quadriceps plasty, Roux Goldweth procedure, and the MPFL reconstruction. And she received this on her both the sides, and you can see after after about 1.5 years, she was able to flex the knee. She was able to squat and do her activity daily. So finally, the bony anomaly cannot be corrected with the soft tissue procedure. This is one of the most important points that we need to learn. A thorough investigation is mandatory to decide the menu. Menu a la carte approach is the best approach at this moment, but we have to create our individual menu to address the individual problem. And at the end, I'd like to say that there are lots of advancement happening. We have to embrace the recent advances and improve our surgical skills. With this, I'd like to thank everyone for patient listening. Thank you very much.